welcome to yet another Newslaundry webinar. This is part of our series on navigating the second wave, where we talk to experts and get our questions answered on COVID, the pandemic, the vaccines, the treatments, and everything. So subscribers, if you have questions, you can enter them in the Q&A box at the bottom, and I'll get to them at some point. I have my own questions as well, and we've got questions that we've received on social media. So our guest for today is Dr. Gagandeep Kang, and it is very difficult to summarize her entire career into a couple of lines, but I'll do my best. So Dr. Kang is a virologist and a professor of microbiology at the Division of Gastrointestinal Sciences at Christian Medical College in Vellore. She is one of India's most eminent medical scientists who played a critical role in the development of the indigenous rotavirus vaccine. She's also the first Indian woman to be elected a fellow of the Royal Society. So thank you so much for coming, Dr. Kang. We really appreciate it.
Happy to be here. Thanks for having me, Jayashree.
Thank you. So I know that you're extraordinarily busy at this time, so we'll just jump straight into questions. So starting off, I think there are a lot of people who are worried about people who are fully vaccinated, but who are getting COVID again. I think you call it breakthrough infections. And I think yesterday, Dr. Soumya Swaminathan of the WHO had said that India's double mutant strain could potentially be resistant to vaccine protection. So my question is, do we have any clear data on this? Is the government sequencing viral genomes of those who have had breakthrough infections? Basically, is this something we should be worrying about?
So actually, I'm happy to be a little reassuring about this insofar as the data we have at the moment. So we have this double mutant, which is the variant B1617. And that has 3 lineages in it.
Okay.
This has now spread to many countries around the world. And there are data where this has been evaluated the strain has been evaluated for the ability of people who have been either vaccinated or infected previously, for them to be, their sera to be able to neutralize these viruses. And in the evaluations that have been done, it's been shown that yes, people who have B1617 need a higher level of antibodies to be able to neutralize this virus compared to ancestral viruses. But to compare that, one way we could do it is look at the UK variant. Now, if you look at what's happening with the UK variant, which is B117, that variant has been circulating in the UK from September last year and really ramped up in December of last year. The UK lockdown, the UK started to use vaccines, but this variant kept increasing and became the predominant variant circulating in the UK. They vaccinated with the Pfizer vaccine and with the AstraZeneca vaccine. We are in a situation today where the UK is opening up. So the vaccines were able to work against the variant. Now, if you look in the lab at how the UK variant performed against people, against sera from people who had been infected with an older version of the virus or vaccinated with vaccines that were made based on the older version of the virus, you found that in the UK variant also, there is a requirement for a higher amount of antibodies to neutralize. So let's say if you needed a level of 1 to be able to neutralize the old version of the virus, for the UK variant, you need 2.
Right.
And if you look at the Indian variant in the lab, it looks like the 3 lineages are a bit different, but somewhere between 2 and 5 is the amount of neutralizing antibody you need to be able to neutralize the virus. And most everybody has enough to be able to do that. So when we think about people getting infected now after they've been vaccinated, I'm betting that most people are not having severe disease. If they are getting infection 3 weeks after they received the first dose of vaccine, most of them are likely to have a mild form of illness. Vaccines are working. And while Soumya is right to cast doubts till we have a final real world answer for B1617, I think the likelihood is high that we will have reasonable protection.
Right. So, and also speaking of the UK, I think they're now advising those under 45 to not get the AstraZeneca vaccine, I think, out of fears of blood clotting. But I mean, in India, we have only 2 vaccines available, and the majority vaccine is Covishield or the AstraZeneca. So is that again something we need to worry about? Or
okay, so let's look at what this blood clotting is about, right? So what's been seen is that people develop blood clots in large veins. So the cerebral venous sinus in the brain, right? Splanchnic veins in the abdomen. So these are large blood vessels and you develop a big clot in them. And along with the big clot, you get a drop in your platelet count.
okay.
The reason that this happens is some people produce an antibody directed against a protein that is released from platelets. This is platelet factor 4. And this seems to be idiosyncratic. It's completely unpredictable. Some people make antibodies to platelet factor 4 when they are given this vaccine. Those antibodies cause clumping of platelets, which leads to clot formation and leads to a reduction in platelets. Now, how often does this happen? It looks like it happens 1 in 100,000 to 1 in 200,000 approximately of vaccinated people. Why has the UK made this recommendation age specific? Well, you have to look at the risk of severe disease or mortality when you get infected with SARS-CoV-2. We know that there is an age distribution. Your risk goes up as your age goes up. Now, to decide whether to use a vaccine in a particular age group or not, you have to do a benefit risk assessment. What are the chances of having severe disease and dying at age 30 or 40 or 50 or 60 if you are infected with SARS-CoV-2 versus the risk of giving people the vaccine and then having this blood clot and thrombocytopenia in people who are 30, 40, 50, etc. Right. So what we know is that in a situation where you have less virus circulating, right, you will have a risk that is somewhat greater in younger people from vaccination because their risk from the disease is less. If there was a lot of virus circulating in the UK, then the risk-benefit analysis would still be in favor of giving the vaccine in that group.
Right. So it's not really comparable for both countries at all.
It's absolutely not comparable. And the other thing to point out is this seems to be different across different countries. So in Europe, they see higher rates, 1 in 100,000. And in the UK, it seems to be 1 in 250,000. What's the rate in India? We don't know.
So my next question is, I think before even COVID started, you've talked a lot in the media about vaccine hesitancy. You said that that's something that does happen a lot. So especially now, and I know you must get this question a lot, which is, which vaccine should I take? Which one should I pick? Do you see hesitancy still being a problem in India right now? Is that why?
Well, it depends on who you're talking to. So if we look at people in the communities that we work with, a lot of them think that this is not a vaccine for them. There's been a lot of misinformation and disinformation, and people are still saying this is not a disease that affects us. This is a disease of other people and not us. And I think that to some extent is changing in the second wave. But there are still people that are quite reluctant to get the vaccine for a variety of reasons. in the upper socioeconomic group because they're worried about vaccine safety, and in lower socioeconomic groups because they've been told that, one, the vaccines don't work, or the vaccines can lead to conditions like infertility or sterility. So there is vaccine hesitancy across many parts of our population. There's also vaccine eagerness, hunting for a vaccine all over the country. And it's such a waste of time and effort, quite frankly.
Yeah, I think there are a lot of reports of people going to rural areas because it's easier to get an appointment on the CoWIN app and so on. So, and then they use up the stocks there as well. So, so I'll take a couple of subscriber questions. One person says, I got infected with COVID immediately after my first Covishield dose. Do I need to get the second dose, and after how many weeks? Would it be safe?
So the reason you get infected immediately after your first dose is because the vaccine hasn't started to work yet. When you take the first dose of vaccine, it takes about 3 weeks for the protective immune response to kick in. So you are still susceptible for at least 3 weeks. Now, when you get infected at the time that you've just taken a vaccine, you're going to have immune responses that overlap. With Covishield, even when we talk about vaccination, the recommendations are variable, but I'll go with the WHO one, which is that you can wait 3 months before getting your second dose of vaccine. It's also what is being used in the UK and has been shown to work really well. It's been largely 1 dose of Covishield and 1 dose of Pfizer that have led to the UK being able to open up. So yes, vaccines are working well. So now when do you take your second dose? Well, we know that an infection gives you at least 7 months of protection at a rate of about 80%.
Right.
We also know that vaccination with 1 dose gives you about 80% protection against severe disease for at least 3 months. And that's the real world data from the UK. So my advice, wait anywhere between 3 to 6 months, you'll be fine.
So I had a question about Sputnik, which I think will be the next vaccine that will be available to us. So I think the Brazilian regulator and so on had raised some concerns. So what do you think about it?
I think anytime a regulator raises concerns about a vaccine, we need to take them quite seriously. Sometimes the concerns are a question of just paperwork. And you could argue that this document wasn't in the right format, this information was not provided, etc. And then those are relatively easy fixes. But in other situations, you have more significant concerns being raised, saying we are not seeing what we expected to see, or we are seeing something that we didn't expect to see. And in this case, what the regulator said was that they were seeing no, or at least some evidence that the virus was capable of replication.
So what does that mean exactly?
That means that the virus can multiply when it gets into people. And all of the vectored viruses that we are dealing with at the moment are supposed to be engineered to not be able to replicate. So if something is behaving in a way that it's not expected to behave, then there is an issue that requires greater investigation. So Gamaleya will need to pay attention to what the Brazilian regulators have raised, and they need to fix this. WHO is also reviewing the Gamaleya vaccine and will be doing an inspection of the facilities, just like they did for Sinopharm, which is the first Chinese vaccine to be approved by WHO. And then we will have a clearer sense not only of what their facilities look like, but their quality and their manufacturing are up to speed. In India, our regulators have approved the gamma layer vaccine. I'm not sure whether they have done a site inspection like WHO is planning to do.
So this question is from a subscriber. There have been reports of mucormycosis during the post-COVID phase, mainly in immune-compromised patients and in patients where steroids were used, high amount of steroids were used for COVID treatment. Is there any remedy for this? Is there a way to protect against this? I've also seen a lot of very scary headlines going on about it, so I did want to ask you about it.
So these are opportunistic fungal infections, and it just means that these are fungi that are floating around all over the place. I think if you remember school biology, you remember Muco, which is this long stocky thing with the bulb at the end, and then the bulb bursts and all the spores come out.
Yeah.
Well, that's Muco. And it's everywhere. But the reason that we worry about Muco is that it has a particular predilection for infecting people with diabetes.
Okay.
And the two places where we can find Muco in the healthcare system where it can be because of the treatment itself. One is the treatment with steroids, and there is a lot of unnecessary treatment with steroids that's going on at this time. And the other is in the ventilation systems that we are using. So for people who are dealing with home oxygenation, you have to bubble the oxygen through water, and nobody cleans those. And that's a prime source of fungal infections.
Okay.
So these are deadly infections, but if you are it can be treated. So there are antifungal drugs that can be used. It's a long, slow, and painful treatment. So it's better not to have the infection.
Right. So you'd mentioned steroids. So I know some doctors are suggesting the early administration of inhaled budesonide as being potentially useful even for mild and moderate COVID cases. Is this something that makes sense? Or?
So the general recommendation, at least for us, is that if you have somebody who is over 60, you might want to start budesonide early. But for younger people, generally wait till they develop respiratory symptoms, not otherwise.
So I've got a bunch of questions on social media and from subscribers on the longevity of vaccines. How long will they remain effective? Would we be required to take another shot after 1 or 2 years? Will they protect us from known variants of COVID at the time?
Short answer, I wish I knew. Right now, it looks like the vaccines are protecting really, we've had vaccines in use since December.
Yeah.
So far, we've seen no waning of immunity in people who were vaccinated early. There are also people who were in the clinical trials who are being followed up, and we will have data from them. But really, they were immunized only about 2 or 3 months before we started to have the vaccines used in the general population. So I think this is something that we will need to keep tracking to figure out how long protection lasts and whether protection is going to be the same. I mentioned the differing levels of neutralizing antibodies that you needed for different variants. Well, that's in the lab.
Right.
We actually have no idea of how this works in people. We know the vaccines are working, but it is the breakthrough cases that we need to figure out. And when I say breakthrough, I don't mean infection. I mean people who get sick with the virus, not just infected. So if we know that in breakthrough cases, they have an antibody profile that is different from people who are protected by the vaccine, then that's where we look for the correlate of protection. What signature tells you that this person is protected and that one is not? So far, we don't have a correlate.
But so in that context, are Oxford and others working on, I don't know how you call it, but updates to their vaccines? So to better tackle new variants or to develop booster shots or something?
So Pfizer and Moderna are already in clinical trials, and Oxford may be in clinical trials. In general, everyone has gone for B1351, which is the variant described from South Africa, because in the laboratory, B1351 was the one that needed much, much more neutralizing antibody to be neutralized. It was the order of 16 to 60 times.
Okay.
And it's also been demonstrated in trials with the AstraZeneca vaccine, with Johnson & Johnson, with Novavax, that even though the Johnson & Johnson and Novavax vaccines worked in South Africa, their efficacy was lower in South Africa when the B1351 strain was circulating as compared to studies in other parts of the world. So yes, wave 2 vaccines based on the variants are in development and have already gone into clinical trials. But one of the things that Moderna did that was particularly interesting was that everybody gets 2 doses of the Moderna vaccine. Moderna went back and identified people who were vaccinated in the first trials that they did, so a year ago now.
Yeah.
And then revaccinated those individuals with either another dose of the old Moderna vaccine or a dose of the new B1351 based Moderna vaccine.
Right.
And they found that actually just giving a booster of the old vaccine also resulted in a broadening of the immune response. It was not as good as giving the B1351 in order to be able to neutralize B1351, but it definitely produced a much wider, better immune response once you had booster.
Another subscriber question: can people who have been vaccinated still be asymptomatic carriers of the virus?
Yes, it's possible. So vaccines are not intended to protect against infection. They are intended to protect against disease. And they do that very well. But we also have data from the UK showing that in real life, in something like a household, which is a high transmission setting, you get a 50% reduction in household transmission with either the AstraZeneca or the Pfizer vaccine with a single dose. So we will see a reduction in spread once we start vaccinating more widely.
And how reliable is the speculation about children being more susceptible in subsequent waves? Is there any serious vaccine testing efforts for children in India? I think he's putting it at above 8 years.
So children for respiratory infections tend to be a source of infection. So that's why for influenza, vaccinating children is recommended, not because the kids get sick themselves, but because the children spread disease to adults and the elderly. Right. So it's protecting the population by vaccinating the children. Some protection for the children, but also protecting other age groups in the population. I think that's likely to happen for SARS-CoV-2. I can't imagine a respiratory virus that would behave that differently. So far, all respiratory viruses, children really matter for transmission. Now, are more children getting infected this time around? Well, I have not seen the data.
Right.
One of the issues with India is that there is a huge lack of clinical data, and everything that we hear is anecdotal. Children are infected, younger people are infected, younger people are getting more serious disease this time. I haven't seen the data that backs that up. So it's really anecdote at this time.
And with the inadequacy of gene sequencing facilities, will we ever conclusively know the spread of variants in the Indian population?
I think sequencing is going to become more widespread and easier. We've only just gotten started with this INSACOG stuff. And in India, we tend to be slow to set things up.
Right.
But I think this is something that we almost have to do if we are to track infectious diseases in the future. It's not just about SARS-CoV-2. I think for all infectious diseases, moving to molecular surveillance just makes sense. So more sequencing, absolutely.
Yeah. So how much of a gap would be okay between doses? Also, if you take if you say you take Covishield as your first dose, do you necessarily have to take Covishield as your second?
If you think about it in immunological terms, what you want as a gap between doses is the longest possible gap. So about 4 to 6 months is good.
Okay.
But what we usually do is try to shorten the gap because we want to cover people with doses as quickly as possible, give them a bit of an extra boost to their immune response. So for Covaxin, we know that the gap should be 4 weeks. Usually you don't recommend any vaccine with a gap of less than 3 weeks. And Covaxin has been tested at a 4-week gap, and we should try to stick to that. What happens if you get a Covaxin and then you don't get Covaxin for 6 weeks or 8 weeks or anything else? Doesn't matter. Just take it when you get it. You don't need to start over. The second dose will in fact work slightly better if you take it a bit later.
Okay, that's okay. I had no idea about that. I thought the 4 to 6 week was a very scientific sort of estimate.
It's sort of the minimum.
Okay.
It's not the optimum.
Right. So I want to ask about various kinds of treatments. I mean, you're seeing a lot of people rushing to get plasma and all sorts of therapies. But apart from, I think, anticoagulants and so on, the data seems to suggest that these treatments are at best of limited utility in a limited window. But so do you think there needs to be better communication about this to the public and doctors? Because we're now seeing 5-hour queues at like Kilpock Medical College to buy remdesivir, for example. So what can we do to avoid this or to work it out?
So I think it's important to understand how SARS-CoV-2 works. We all know you get infected with the virus. 80% of people will have asymptomatic or mild disease. 20% of people will have moderate or severe disease. Of that 20%, 17% will be people who can manage either at home or just on an oxygenator. They will get better. They don't need anything more than paracetamol.
Right.
And if saturation drops, maybe oxygen for a while, that could be a concentrator. It's the 3% that need to wind up in hospital that we need to worry about what we want to do. When you get infected, the virus enters, begins to multiply, multiplies for 5 days. That's your incubation period, and you start to have symptoms after that. The virus continues to multiply until your body shuts it down. And that's usually a maximum of a week after you develop symptoms, maybe 10 to 14 days after you acquired the infection.
Right.
After that, it's really your immune system that is responsible for everything else that happens because virus replication has been shut down. Now, your immune system has gone into overdrive. And what you need to do to control the severity of infection is really to shut your immune, give supportive therapy, try to make sure that the person is comfortable, can breathe, but try to shut down the immune system reacting as badly as it's doing. And that's where you give steroids.
Okay.
What do you give remdesivir for? Remdesivir is an antiviral. Who do you give remdesivir to? Ideally, an antiviral should be given when viral replication is taking place. So that means develop symptoms, and potentially if you had an antiviral, that's when you would use it. My test is positive, let me use an antiviral. But remdesivir is IV. So you can't use an IV drug at home till you get severely ill. So the point at which you get to hospital is when you should get remdesivir, assuming that it is in the first week of illness.
Right.
After that, when your oxygen requirements is increasing very rapidly, then you want to shut down inflammation, and that's the point at which you need to use your tocilizumab.
Right.
So remdesivir early, tocilizumab is later before you go on to a ventilator.
And plasma, the plasma.
Plasma, there's only one study that shows that plasma works. And that is if you have plasma with a high titer of neutralizing antibodies given in the first 3 days of illness before people get to hospital. Once you're in hospital, it's already too late. So that's why we say, don't run around about plasma. If anybody is sick, you're already beyond the point where plasma will work.
Right. Okay. So again, a subscriber question. What was the reason? Why did the first wave subside on its own without any major evidence? Can we expect a similar thing to happen with the second wave? And with the third wave being announced, what should people ideally do in this situation? Can they go out? Can they go back to work, even if they wear masks and socially distance?
So, big open question to me is, why did the first wave have the size that it had? And why did it stop? I don't have an answer to that.
Right.
So, given all the sero surveys that we've seen, I think it will be a complex answer that consists of social mixing patterns, the variant that was circulating at the time, as well as the interventions that had been put in place. I don't think that that is a complete and full explanation, but I think it might explain 80% of what we saw at the time.
Okay.
Oh, second wave and third wave. Will the same thing happen in the second wave? Well, waves are waves because they follow patterns. They go up and they go down. Now we are in a situation where we are up and maybe we are at the top. But really, a wave is going down when you have at least a week of results that are behaving the same way.
Okay.
So if there's a lot of variation in testing that happens. Certain days of the week, labs don't test. Once you have a stable pattern for a week or a trajectory over a week, then you can say, okay, now I can see where we are on that curve. Third waves, I don't think it will be third waves. I think it will be third, fourth, fifth, sixth waves.
Right.
Because I think this virus will settle down with time. And we'll need to wait until that happens. The best way we can deal with it is keep up with the interventions that we have now and make sure that we get vaccines when they become available to us. I think the biggest thing is this is serious. It needs to be taken seriously. But it's very important to remember that, we're all in this together, and panic and desperation doesn't help anybody.
Yeah.
So let's see what we can do to support each other as much as possible and prioritize the people who are the most vulnerable and who are more likely to have severe disease.
Subscriber question. There are a lot of conflicting questions doing the round regarding the minimum CT value of N gene to identify whether a person is COVID positive or not. What is your opinion? And in brackets, which I value greatly.
So the PCR tests that have been set up are actually qualitative tests. They are not intended to tell you quantities.
Okay.
Because it is a real-time test, you get quantitation. But there are no two tests that are exactly the same. So a CT value of 20 on one test may be 27 on another test. So we can't compare. And I wouldn't worry too much about it. If we want to do a quantitative test, then you need a quantitative control that you can bridge back to a viral copy number. Okay. And that requires for you to have either an RNA control or a virus that you can include, inactivated virus that you can include in the extraction process for PCRs.
So I wanted to ask on COVID treatments. The government had said that some of its Ayush treatments can, and I quote, help treat asymptomatic mild and moderate COVID infections as an adjunct to standard care. And in Chennai, for instance, I know that the corporation from last year has been distributing Kavasura Kudineer, though some doctors have now said that not only will it not help, but it could even be potentially harmful. So what are your thoughts on this, and how much faith should people put in this or not?
I think anything that makes you feel more comfortable is fine. And I have, for any Ayush treatment or any other form of treatment, I'd like to see it evaluated first. And I'd like to see it evaluated without bias. We have not seen that for many of the treatments that have been recommended.
So for people and children with asthma and bronchitis and on long-term schedules of steroids like budesonide and mometasone, do these need to be stopped if the person contracts the virus? Does this become extra tricky?
No, just continue your routine treatments.
Do we have full data on Covaxin to be confident?
So far, we have 2 interim reports on Covaxin, and we've been told that we will have full data on Covaxin sometime in June, and that it will be submitted to the regulators. I'm assuming that we will get full data at that time.
Okay, quite a related question. Do people who take medication for blood pressure and blood thinners need to stop taking them before the vaccination? Is this something to worry about?
Not at all. So the only thing is, people who are on blood thinners, you have to make sure that when you get the injection, you don't rub the site of infection. Just put pressure on it for 3 to 5 minutes, and that's it.
So my question is about the US supporting the TRIPS waiver. Do you see that increasing the vaccine supply in the developing world?
Not in the short term, but in the longer term, and depending on how we use it, possibly. The question is the TRIPS waiver only for the vaccine patents or for all of the other enabling technologies as well? Right. And will it come with a technology transfer package? If it will, then it is possible to think about manufacturing in developing countries and increasing supplies. If it's just vaccine patents, then that is much less useful.
This is a subscriber question. What is the role of inflammatory markers, especially D-dimer, on the prognosis of the disease?
It's measuring inflammation, and it gives you a sense of how much inflammation is going on. But really, when looking at what is happening to determine treatment, some people like to look at rising levels of IL-6 to decide whether they want to use tocilizumab or not.
So is COVID airborne? And can we use the air conditioner right now?
COVID has always been airborne. It's a respiratory pathogen. So I think the big difference is what proportion is droplets and what proportion is smaller aerosols, right? So the data on this started to come out around August, September last year, when the National Academy of Sciences published a report showing that actually when you have a number of different activities, you produce particles of all sizes. It's not like everything is above 5 microns and then you have this small component that is everything else. Any activity is producing particles of many different sizes. The proportion may vary. What is called aerosol generating procedures generate more aerosols and fewer droplets. And something like talking might, at least talking softly, will give you more droplets and less of smaller particles.
Right.
So in terms of using the air conditioner, it depends on how much air there is recirculating in the room. And over time, in a room that does not have multiple air changes, you will get a buildup of infectious particles, which makes that room a place where more infections will spread.
Right.
So ventilation is really critical. Making sure that there are 4 to 6 air changes is very important.
Is there any understanding of who may get what kind of side effects? For example, those who got AstraZeneca had flu-like body freezing symptoms the next day. Others had bad stomach. Was that seemingly related to blood hemorrhaging?
No. So the hemorrhaging we've discussed before was a really rare side effect. A lot of people thought that, something like heart attacks or strokes, which are also related to clotting, were due to the vaccine. That is absolutely not the case. In fact, in some of the studies that have been done, these kinds of events have been below baseline.
Okay.
So fewer strokes and fewer heart attacks compared to what you would have expected to see in the period following vaccination. It really depends a lot on the quality of data. But different side effects are related with different vaccines. So Covishield definitely causes flu-like symptoms. It's worse with the first dose, better with the second. The Moderna vaccine and the Pfizer vaccines cause more symptoms after the second dose than with the first dose.
Okay.
Inactivated vaccines in general have lower side effects than other platforms.
Right. The Feluda test by Tata MD was supposed to be very fast, accurate, and cheap, but it seems to exist only in press releases. Is it available in the market? Why is it not talked about more?
From people who have used the Feluda test, I'm told that it is a really good test. The problem is when it came to market. And if you already had a setup for doing real-time PCR, then you didn't need to establish the Feluda test, which uses a regular thermal cycler.
Okay. Is it safe for pregnant women, people with underlying health issues, or immunocompromised patients to get the COVID vaccine?
Vaccines are not usually evaluated in pregnant or lactating women, so that's always been a problem, making recommendations. But if you look at it, pregnant women have a high chance of poor outcomes if they get infected during pregnancy. So the current recommendation from most professional bodies and many advisory committees is that pregnant women should be given vaccine at the same time as anybody else in their age group.
Right.
Earlier, it was only for healthcare workers, saying healthcare workers are at greater risk of exposure. So after discussion with them, the vaccine should be offered to them. Now it's been opened up into a more general recommendation that any pregnant woman can ask for and get the vaccine. And for lactating women, it's absolutely fine.
Okay.
Currently, this applies to all the vaccines that are available. If we wind up in a situation where we have a live vaccine, then those vaccines are generally not recommended for pregnant women. But at the moment, none of the vaccines we have are live vaccines.
Okay. So when should a CT scan be done? Because many doctors are prescribing it even in mild and moderate cases. I've also seen a lot of headlines recently on CT scans and cancer. So I think
a CT scan should be done when your doctor thinks it needs to be done, and definitely not outside of a hospital setting.
Okay.
Definitely not for mild and moderate disease. I would go by respiratory rate, and anybody who has a respiratory rate of below, at least 24, would not think of getting them a scan at all.
Do we have enough proof to say that the virus particles survive differently on different surfaces for varying time periods?
Yes, we do. It depends on humidity, it depends on temperature. So for viruses, looking at surfaces, this is the kind of experiment that everybody likes to do. But you need sufficient virus to be picked up off those surfaces and transferred to your respiratory tract for these kinds of surfaces to be dangerous to you. And that, in most situations, is not going to be a high amount.
So a subscriber question. The IMA has recommended the formation of Indian medical services. Do you support this? And in your opinion, which experts other than medical doctors would be a part of it?
I think one of the important things to recognize is that all of medical care is a team. So if you create an Indian medical services, then it really needs to be everybody involved in the care of patients, whether that's a respiratory technician or somebody who is a phlebotomist, as well as doctors and nurses. I think we need to think about what we intend to achieve through an Indian medical service. If you look at the model of the National Health Service in the UK, for example, every GP is effectively an independent contractor to the government.
Right.
Is that the model we are looking for? Or are we looking for our current approach, which hasn't worked very well, which is that in the state service, if you teach or you work in a hospital, you are a government employee, but you also have the freedom to do private practice. So I think evolving a system that offers service should first look at what are the services we want to offer, and then think about how to do it.
Right. So there are several questions on when are you most infectious when you test positive for COVID? Also, does alcohol impact vaccinations or the efficacy of vaccinations?
You're most infectious at about the time you develop symptoms. You can be infectious for up to 2 days before you develop symptoms. And then the first few days that you're symptomatic is when you are shedding the most virus. Alcohol does nothing to the virus and probably does something to you, and calibrate that.
Right. And in a possible follow-up question, would you recommend any diet? Is diet even something that we should worry about?
Diet is something that everybody should worry about in terms of making sure that you really have diversity in the food that you eat. But in terms of building immunity or affecting how you do with the virus, go with what you're comfortable with.
Okay. Do you see Moderna and so on being available in India in the near future?
There are already discussions with Pfizer and Moderna to bring the vaccines into India. Pfizer has said that it's only going to sell the vaccines to the government. So some state governments are talking to Pfizer about purchasing vaccine. It will be expensive. Moderna will more likely go into the private market.
Okay.
But we'll have to wait and see what the negotiations are. Right now, everything that Pfizer and Moderna are producing is already booked. So we are really late to the table.
Right.
I doubt very much that we will get a significant number of doses of either of these vaccines before the end of the year. Token amounts we might see, but I don't think we'll get a lot.
Because even anecdotally, I know a lot of people who have decided that they'd rather wait till these vaccines come to India. And I think the consensus is that that makes no sense, right? Should you just take whatever vaccine you can get at this moment?
Take whatever vaccine you can get at the moment. And if it turns out that we will need boosters, then you can choose which booster you want to get.
Yeah.
Right now, we have no understanding of mix and match schedules, but there are studies that are ongoing, and we will have more data that will guide decision making in the future.
Right. So do single dose vaccines work better than the 2 doses that we are seeing now?
We know that the Johnson & Johnson vaccine is working well with the single dose, and even Pfizer and Moderna start to protect people about 10 days after the first dose of vaccine. Will one dose be sufficient? Actually, we don't know at the moment, because most of the other vaccines, except for Johnson & Johnson, have been 2-dose vaccines.
Okay.
But with Moderna and Pfizer, the reason for going for 2 doses, and with the inactivated vaccines for going for 2 doses, when you did immunogenicity of the vaccines, measuring immune response, you saw very little response after the first dose in terms of neutralizing antibodies, and then a large jump with the second dose. So that's why it was decided to make this into a 2-dose schedule. Okay. Do we need those neutralizing antibodies? We don't know, because we haven't got a correlate of protection.
Right. So it is said, mostly anecdotally, that in Andhra Pradesh, certain communities are being affected higher than others. Are you getting hard hit with high mortality rates? Is there any truth to this? Does the impact of the infection depend on genetics, community genetics?
It's possible with any infectious disease. It is feasible that there may be a genetic background that makes you more resistant or more susceptible. But until we study it in greater detail, we won't know. There is a paper published today in bioarchives that seems to indicate that there may be increased susceptibility depending. You remember there were some publications about Neanderthal genes and how they influence susceptibility. This new paper shows that there may be some overlap with that, but until we study significant numbers of affected people or unaffected people, it's very hard to say.
So this would be all the data that we may have in a few years or even longer or something.
That's right. But with most infectious diseases, all of these genetic things start out sounding really good. You know, this blood group is infected with this particular virus, and we know that blood group antigens are receptors for certain kinds of viruses. But then when you look long enough, you find that the viruses have evolved that if they, if this blood group is resistant, they find another blood group that they can attach to. So there's no getting away from this.
Right. So in this sort of national level vaccination drive, what role do you think the media plays in it? And how do you think the media has been doing so far? Because science reporting is not something that's ever really prioritized in most mainstream papers. So now everyone is scrambling to get the science right, but also to deliver as much information as they can. So what is your take on it?
I've been very impressed by many of the young journalists that I've been speaking to, because they really take pains to get to the bottom of a story and try and understand what the science is before they write their stories. That's not, of course, the case 100% of the time. And I know that people are under a lot of pressure to get stuff out. Where vaccines specifically are concerned, I think sometimes there is such a hurry to have a catchy headline that safety issues get blown out of proportion without emphasizing how rare they really are.
Right.
So having balanced stories on safety would be very important. And we haven't necessarily seen those. But also it's important to emphasize that vaccines are not 100%. No vaccine is perfect. And we need to understand that in many situations, when there's a lot of virus circulating outside, you still need to have precautions, even if you're vaccinated.
Right. So I think we'll have time for just maybe a couple of quick last questions, and then we can wrap up, because I know you're really busy as well. So this is a subscriber question. With the current vaccination speed, it's projected that it'll take 2 years to vaccinate the entire population. It's also being projected that vaccine immunity won't last for more than a year. Do you think our attempts to build herd immunity will be futile?
So I think herd immunity is going to be hard. So we did think that herd immunity was something that we could aim for. But if you're going to have so many different variants, will the variants evolve to get to a point where they can reinfect people? If that happens, no question of herd immunity. It's possible that, after you've been infected 3 or 4 times, or if you've been vaccinated with 2 doses and a few boosters, you may evolve a broadly protective immune response. In which case, if a large part of the population gets to that point, we will get to pretty close to herd immunity, but not in the near future.
Okay. And my last question, will vaccination get easier and more streamlined if instead of people coming to the government, to hospitals and clinics, the government goes to the patients, which is similar to what was done in the pulse polio program?
I think it needs to be a balance. So it takes a lot of resources to send a team of people to vaccinate one person. So wherever it's feasible to bring people to a center, that's fine. But certainly if we want to achieve reasonable coverage, we have to make sure that vulnerable communities and vulnerable individuals are reached outside of this fixed facility immunization. So whether it requires a team to get out there and vaccinate a tribal village, or climb up 9 flights of stairs to vaccinate an older lady, I think it just needs to be done.
Okay. So I think with that, we'll wrap up the webinar. Thank you so much, Dr. Kang, for coming. Thank you for taking all our questions. To those subscribers whose questions we couldn't answer, I'm sorry, but we'll try and cover them in the next webinars that we're planning. So thank you everyone for coming.
Thank you and bye.
Thank you. Bye.